You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 18th, 2018. This week, the topics include device-related thrombosis on left atrial occlusion devices, AF burden after AF ablation, embolic stroke of unknown source, thrombolytic in ischemic stroke, and lipoprotein a. But first, an announcement. I'm pleased to announce that This Week in Cardiology has received its first sign of relevance. A group of academic pharmacologists have written in complaining of my use of the term NOAC for non-vitamin K oral antagonist. They feel the term NOAC can be confused with no anticoagulation. Okay, I didn't know that, but perhaps I should switch to the term DOAC, D-O-A-C. Now, feel free to comment on what we should call these oral anticoagulants. Still to this day, I'm not sure which terminology to use. The first topic is device-related thrombosis on the Watchman. The late physicist Richard Feynman famously remarked that the first principle is that you must not fool yourself, and you are the easiest person to fool. A new study from Watchman investigators highlight the ability of left atrial appendage occluding proponents to fool themselves. This study was presented at HRS and it was published in Circulation, and it details disturbing information on device-related thrombus. Make no mistake, this is not good news for left atrial appendage occlusion proponents. Now, the Watchman investigators studied the incidence, predictors, and clinical outcomes of device-related thrombosis using the 4 Watchman studies, the 2 RCTs, Protect and Prevail, and the 2 registries, CAP and CAP2. This analysis included 1,700 plus patients, and most of the patients had surveillance TEEs. The other good thing about the study is that there's a stable and consistent antithrombotic regimen used in the trials, and pretty much most people know this, that you use warfarin after appendage occlusion with Watchman, and then provided that the TE at 45 days demonstrates no device leak or thrombus, warfarin can be discontinued and the patient takes aspirin and clopidogrel up to a 6-month period, and at 6 months, clopidogrel can be discontinued and aspirin alone after that. So it's a stable regimen. So the main findings of this study was that the incidence of device-related thrombosis was 3.7%. And when device-related thrombosis was present, the relative risk of stroke or systemic embolism was greater than 3-fold higher. Now, this included even a higher rate of intracranial hemorrhage, too, presumably due to intensification or reinitiation of anticoagulation. And in patients with clot on a device, stroke seemed to come closely afterwards, and this temporal relationship suggests that they were causative in terms of the stroke. The predictors of having a clot on the device were permanent AFib, a history of stroke, vascular disease, bigger left atrium, or lower ejection fraction. These predictors make sense clinically. So these are concerning findings, and I really like Dr. Sanjay Kaul's comments in the news story. Dr. Kaul makes the point that you have to consider DRT findings or device-related thrombus findings in the context of the fact that Watchman did not pass muster in the Protect trial and did not meet even a lax non-inferiority margin in Prevail's first primary efficacy endpoint. I would also add that these device-related clots are often occurring in the setting of either warfarin or dual antiplatelet therapy, as half the DRTs occurred in the first 6 months during the time of DAPT. The other half occurred later, presumably when only aspirin was used. And another point to make is that all of the conditions that predicted device-related thrombosis are often present in the patients who are getting the device now, meaning right now we're doing sicker patients with comorbidities who had prior stroke, heart failure, bleeding. So the people who are getting the device now may be the least likely to benefit from appendage occlusion. I completely but respectfully disagree with comments from Dr. Delorgio, who said that he believes that the device-related thrombus does indeed mitigate the benefits of appendage closure relative to warfarin, but he did not believe this mitigates the benefits of left atrial appendage closure with these devices relative to no therapy. I disagree with that. There is not a shred of evidence that this procedure is better than no therapy. Remember, the preventive procedure, this procedure comes with risks. If you tally up the risk of major complications from putting these devices in, and you use the 4 studies that were used in this study, you get an average major complication rate of about 6%. Now you have to add in the risk of the device-related thrombus, and I think it's fantasy to proclaim this is better than no treatment. We need a trial of appendage occlusion versus no treatment, lest we fall into Feynman's trap about fooling ourselves. One final comment about this study: I give kudos to the authors and to Circulation for publishing this sort of sobering data. Second topic is AF burden after AF ablation. Now remember, the CASTLE-AF trial showed that AF ablation reduced the primary endpoint of mortality and heart failure admissions relative to antiarrhythmic drugs in patients who had heart failure with reduced ejection fraction. At the HRS meeting, Professor Johannes Brockman presented a post hoc analysis of the CASTLE-AF trial looking at 3 questions. First, is there an association between AF recurrence and outcomes? Can we predict outcome based on AF burden early after ablation? And what role does the relative risk reduction of AF burden play on clinical outcomes? Now, importantly, Dr. Brockman's analysis was an as-treated analysis, which we know from the Cabana discussion is problematic because it is essentially like an observational study. So the findings of the paper was that yes, AF ablation did indeed improve AF burden. AF ablation also improved the time to first recurrence of AFib. And a high AF burden was associated with an increased risk of having the primary endpoint. But time to first recurrence did not predict clinical outcome. Finally, the relative reduction of AF burden after ablation did indeed predict the outcome, the primary efficacy endpoint. Now, the quick look at this sort of data confirms what we believe, that AF ablation improves outcomes because it gets rid of AFib or reduces AFib burden. A quick look at the analysis also confirms the findings that CASTLE-AF were not spurious. In other words, CASTLE-AF worked because it reduced AF burden. And that's probably true, maybe true, but listeners, I think we must remember that this was a post hoc observational analysis. These conclusions are subject to confounding, as are any post hoc as-treated analyses. And what's more, we should definitely not forget the limitations with the original CASTLE-AF trial, mainly that CASTLE-AF was underpowered. It was terminated before its pre-specified targets had been reached. A large portion of patients were lost to follow-up, and there were small numbers of events in CASTLE-AF, and these findings make the original findings statistically somewhat fragile. I think the take-home message is to remain cautious and to maintain a level of uncertainty about a procedure that entails putting hundreds of burns into the left atrium. Third topic today is embolic stroke of unknown source, and this accounts for about 1 in 5 ischemic strokes. And these are strokes not associated with a proximal arterial blockage, not associated with a recognized cardiac source such as a vegetation or AF or LV clot, and are also not lacunar infarcts. The question is how best to treat these patients. I would have thought that since most are embolic is in the name ESUS, that an anticoagulant would be superior to an antiplatelet. Well, the Navigate ESUS trial compared rivaroxaban 15 milligrams per day to aspirin 100 milligrams per day. This was a big study, 459 centers worldwide. The primary endpoint was simple. It was just stroke or systemic embolism. And the primary safety outcome was also simple. It was major bleeding. Now, always important is to consider who got in a trial. Notably, young people under the age of 49 were excluded, and this has implications for PFO closure. The short story from Navigate ESUS is there was no difference in the primary endpoint, and this 1.1% and statistically higher rate of bleeding on rivaroxaban, and these factors caused the trial to be stopped early. Now, I'm surprised, and this is certainly relevant data. This is the population of people we currently consider long-term AF monitoring or putting in an ILR. Obviously, because if you find AF, you prescribe anticoagulants. Navigate sort of looked at empiric therapy with anticoagulation. Just don't even look, just put the patient on the drug. But it didn't work. Now on Twitter, Dr. Jason Andrade wondered that if the investigators had selected patients more likely to have LA clot, whether rivaroxaban might have worked. Perhaps. And another issue here is whether this negative finding from Navigate-ESUS excludes the need for a PFO closure versus DOAC trial. There are many who think that the PFO closure trials that showed benefit were flawed because aspirin is an inadequate comparator. The reason they say that is if PFO causes stroke by letting venous clot through the LA, then anticoagulation rather than aspirin should be the comparator. Now, the authors of Navigate-ESUS discussed this in the discussion part of the paper, and they concluded that because the presence of PFO was so low in their trial, around 7%, they could not make any definitive conclusions on the influence that PFO had on outcomes. There are 2 ongoing trials in similar patients with dabigatran and apixaban, so before giving up on oral anticoagulation, we should probably wait for these trials. Fourth topic is thrombolysis and stroke. Now this week, the New England Journal of Medicine published another TPA for ischemic stroke trial, and the results are once again very similar to other TPA trials, and in my opinion, they're inconclusive and likely show more harm than good. Let me explain. The Wake Up RCT was a multi-center RCT from Europe looking at treatment of patients in which the onset of symptoms are unknown. Say when you wake up with a stroke, you don't know how long it's been going on. But these strokes are thought to be less than 4 hours based on an MRI imaging. Now, MRI imaging is not as easily done or is not as commonly done as CT imaging. The trial was funded by the European Union but had to be terminated early because of cessation of funding. About 500 patients who qualified on the basis of clinical and MRI criteria received either placebo or alteplase, about 250 in each group. The primary efficacy endpoint was favorable outcome on the subjective modified Rankin scale of 0 to 1. The primary endpoint was indeed positive. 53% of the patients in the alteplase group reached a modified Rankin of 0 to 1 versus 42% with placebo. However, the ultimate endpoint is death or dependency at 90 days, and here from Table 3 in the New England paper, there was no statistical difference in this outcome. As for safety, symptomatic intracranial hemorrhage was 2% alteplase versus 0.4%. This was not statistically significant. More importantly, 4% died in the alteplase group versus 1.2% in the placebo group, and this had a p-value of 0.07, so a very strong trend. This direction of data is the same with all thrombolytic trials, and here's the deal. Yes, there is a small benefit in terms of a subjective endpoint. Now note the difference between a modified Rankin score of 1 to 2 is important because the authors make a 1 a positive score, but a 2, which is slightly more mild impairment, the same as death. And so it's this dichotomization of the modified Rankin score that makes this subjective improvement very difficult to interpret. And all this has to be balanced against a clearly higher risk of intracranial hemorrhage and death with the thrombolytic therapy. Even the editorialists expressed caution and called for maintenance of clinical equipoise so that confirmatory trials can be performed. And I certainly agree with that. Last topic today, little change of pace, is lipoprotein a and PCSK9 inhibition. Now, after publication of the 2 big PCSK9 inhibitor trials, Fourier and Odyssey, 2 things have become abundantly clear. The first thing is that the drugs do reduce the risk of cardiovascular events, but they also cost a lot of dollars. And high cost and these modest reductions in CV events means we have to try and find patients most likely to benefit from the drugs. Now, the Heart.org Medscape Cardiology contributor, Dr. Michelle O'Donoghue, from the Brigham and Women's Hospital, presented a pre-specified analysis of Fourier looking at how evolocumab affected levels of little lipoprotein a. She made the presentation in Portugal at the European Atherosclerosis Society meeting, and the reason for this analysis is that previous Mendelian randomization studies suggest that lipoprotein a plays a causal role in the risk of coronary heart disease, and PCSK9 drugs do indeed reduce lipoprotein a. Now, this sub-study found that evolocumab did reduce lipoprotein levels about by 25%, And the greatest effect of the drug compared with placebo on the risk of cardiovascular death, MI, and stroke was in patients who had higher baseline lipoprotein a levels. So it was a 24% relative risk reduction in those patients versus 15% in those with lower levels of lipoprotein a. So it's a twofold increase in the absolute risk reduction in patients with higher lipoprotein a levels. In general, higher risk people in the trial had higher levels of lipoprotein a, and the lowest risk was achieved when evolocumab reduced both lipoprotein a and LDL together. Now, a commenter quoted in a news story outlined the uncertainties of lipoprotein a and CV risk reduction. And I learned these findings are sort of a teaser for ongoing trials of antisense nucleotides which target lipoprotein a specifically. We shall see if these agents further lower risk, though I must say the problem here for lipid management is the problem of diminishing returns. I mean, how much more reduction in events can we expect in patients who follow a heart-healthy lifestyle and take statin drugs, for instance, and at what cost? So that's it for This Week in Cardiology. I'm grateful that you listened. Thank you. Remember, next week is a holiday, a Memorial Day holiday. This Week in Cardiology will take a week off, and I'll see you back the following week. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.